Welcome, Bodhi.
And we're now live on Facebook.
Good morning. Welcome to Black History Month presentation event for the 17th of October. I'm Emil Brown. I'm one of the co-chairs for the REACH network at CUH. We have Dr. Dami Collier in today to do a presentation. I'll just give some background. The presentation will be on advances in HIV infection. It's a lot of work which has been done by Dr. Dami Collier herself and her team. But before I go on, I'll just give you a brief background of Dr. Collier's work. Dr. Collier is actually a clinical lecturer at Department of Pathology, specializing in infection diseases and virology. She was a welcome clinical PhD student at the University College of London and the Africa Health Research Institute, where she studied intra-host evolution of HIV. At AHRI, Dr. Dami started the HIV escape and resistance in the brain study, which aims to investigate the occurrence of independent replication of HIV in the brain of South African patients with neurocognitive impairment, and to study the evolution of drug resistance in these compartmentalized viruses. Her research interest extends to other diseases of global health significance, including SARS-CoV-2, and her work has contributed to knowledge about viral variants and vaccine-mediated immune response to these emerging variants. So without further ado, I'll leave the platform for Dr. Collier to start her presentation. Welcome, Dr. Collier.
Thank you, Emil, and thanks for the introduction. Good morning, everybody. So I'm currently a clinical lecturer and infectious diseases virology registrar here at Addenbrooke's Hospital and with the Department of Pathology at the University of Cambridge, where I've continued to follow up on some of the work I did during my PhD around intrahost evolution of viruses. So my talk today is really to give you a broad overview of advances in the field of HIV medicine over the last 4 decades. So actually, I'm not going to spend much time at all talking about the minutiae of the work that I do, but to give you a general overview of advances in treatment, in cure, prevention, and vaccines. So I quite like this timeline that was published in Cell in 2020, which gives an overview of the timeline of HIV and scientific advancements over the course of the last 40 years. So HIV was first identified in 1981, where patients presented with the clinical syndrome of opportunistic infections, mainly PCP pneumonia, and Kaposi's sarcoma syndrome, mainly in people who had been infected by blood transfusions, intravenous drug users, and men who have sex with men, which I will refer to as MSM during the course of the talk. So that was 1981, the year I was born, and then transmission routes were then elucidated quite soon after that. And in 1984, HIV was then identified as the causative agent for AIDS, so which is acquired immunodeficiency syndrome. Following that, rather quickly, the first therapeutic targeting this virus was identified, called zidovudin, or AZT. But it wasn't actually approved and used in clinical medicine for almost another 2 years. So by 1995, the very first vaccine targeting HIV was developed and trials began, but it's been near enough 3 decades since, and as of yet, that field of HIV advancement and development has been rather disappointing because we don't have an efficient or effective vaccine as of today. In 2010, the very first randomized controlled trial using antiretroviral drugs as prevention for HIV transmission was published. And this was, really landmark studies that show that a dose, so a pill a day, could prevent uninfected individuals from acquiring HIV. And in 2011, the first hopes of eradication or HIV cure was demonstrated in the Berlin patient who received a bone marrow transplant from a donor who had a special mutation in the CCR5 receptor, so a delta 32 mutation that rendered them immune to HIV, and he was demonstrated to be cured from HIV. And following on from that, we have this concept of U equals U, which I'll go on to describe a bit later on in the talk, whereby we now know that in patients who receive effective antiretroviral treatment and remain virally undetectable by our standard lab assays, these individuals are unable to transmit HIV to their sexual partners. And then following on from the Berlin patient cure, another patient emerged, the London patient, who also received a delta 32 CCR5 mutation bone marrow transplant and has been shown to be cured of HIV. So looking globally at the epidemiology of HIV, it still remains a virus of global health concern, with 38 million people living with HIV. These are UNAIDS data from 2020, and 28 million of these individuals are receiving antiretroviral therapy as we know it now, which is generally a combination of 3 pills, usually with a backbone of 2 NRTIs and another drug to complement this, either an NNRTI or PI or integrase inhibitor. So it's a cocktail of drugs, usually 3 agents, to achieve viral suppression. And on the right-hand side, we see that since the initiation of combined antiretroviral therapy, uptake across the globe for various regions of the world has sort of continued to exponentially increase, which is good news. And back in 2015, the UNAIDS had this ambitious goal, which they called 90-90-90, which means that 90% of those who are HIV or living with HIV know their status. 90% of those then go on to antiretroviral therapy. And of those who go on to antiretroviral therapy, 90% of those are virologically suppressed by standard assays. And the aim was to have achieved this across the globe by 2020. Unfortunately, we didn't achieve those goals, and this is where sort of the status of the world was at the end of 2020. So 81% of people who had HIV knew their status, 67% of those had gone on to antiretroviral therapy, and of those, 59% of those were virologically suppressed. So those are data from the globe. And then in the UK, we have just over 100,000 people living with HIV, and we have managed to achieve those 90-90 targets. So 93% of those who are infected know their status. Of those, the vast majority, 97%, are on antiretroviral therapy, and of those, the vast majority, again, have achieved virological suppression. So it's, some things to be pleased about with regards to progress in the UK. And these data I've put side to side. So these are new infections of HIV in the United Kingdom. So incidence. So tracking from the late 2000s, so 2009 up to 2018. And then on the right-hand side, the graph again shows new cases on the y-axis and more recent data, which has recently been released by UKHSA. So really, from sort of, the mid-early 2010s, we've seen a steady decline in the incidence of HIV across all strata. So gay men, bisexual men in the top maroon line, with a steep drop from 2015, which is all good news. And then heterosexual women and heterosexual men had continued to fall steadily since the 2010s. And we see that reflected in this graph as well on the right. So from 2017 to just up to the pandemic, we see this steady drop in incident cases of HIV amongst MSM and heterosexual men and women. However, since the global pandemic, we have seen a flattening off and possibly a slight uptick in the numbers of new cases of HIV. And most of this is all down to the progress that has been made is down to increased testing, the availability of PrEP, so treatment as prevention of transmission, and education. But obviously we've got to keep an eye on this because the work is clearly not done yet. So I like to show this graph because HIV-associated neurocognitive disorder is of interest to me, but also it just shows what has been achieved with the advent of combined antiretroviral therapy. So as I described earlier, a cocktail of drugs of varied classes, it designed to achieve sustained virological suppression in patients. And so prior to, so before AZT was given as treatment, on the graph here on the y-axis is the incidence of HIV dementia, which is the most severe type of HIV-associated neurocognitive disorder. And it was actually rather common in the pre-ART era, such that up to 50% of those who presented with advanced AIDS actually presented with HIV dementia. And we can see that the incidence of that was up at a sort of 20 per 100,000 person years. And then in the mid-90s, so single drug antiretroviral therapy with AZT was introduced, and we see a slight effect of that. So a drop in the incidence of HIV dementia. And then by the late 90s, we have combined antiretroviral therapy as we know it now. So the three drugs from at least two different classes, and we see a marked decrease in HIV dementia. These data are from America, so it's from the multi-center AIDS cohort study, but these data would be reflected in other settings as well. Perhaps the timing obviously would have been shifted because most of sub-Saharan Africa didn't get access to combined antiretroviral therapy until sort of the late 90s and early noughties. Okay, so this is something that's sort of come along, long-acting injectable antiretroviral drugs. So in general, most of our patients take three drugs in various combinations. If they're lucky enough, it's 3 drugs in 1 pill, so a pill a day, which is great. Some patients have to take 3 different drugs in separate combinations. And what's come along since is the option of having injectable antiretrovirals, which will allow patients to have an intramuscular injection either monthly or bi-monthly. And this is slowly being introduced even in the NHS as we speak. So I've just highlighted 3 landmark studies that demonstrated the efficacy of this approach. So the FLAIR study randomized just under 600 patients to either have the long-acting combination of cabotegravir and rilpivirine, which are 2 different classes of antiretroviral drugs, versus an oral daily combination of dolutegravir, abacavir, and lamivudine. And they looked at this 2 ways. So they looked at, so basically they set up margins of non-inferiority. So they looked at the percentage difference in essentially experiencing virological failure. So viral load greater than 50 cells per mil. And they found that actually whether you had that the injectable arm didn't cross the non-inferiority margin, so was equally as good as the oral arm with regards to whether an individual failed treatment demonstrated by CD4 viral loads of greater than 50. They then looked at it in the converse, so the percentage difference in those achieving virological suppression at less than 50 cells per mil at 96 weeks. And again, they've set up the margin of non-inferiority as 10%. And what they find is that the injectable arm didn't cross over into the non-inferiority margin. So that was good news. So certainly the FLAIR study has demonstrated that injectables are non-inferior to oral treatment. And then they then looked at those with confirmed virological failure at various time intervals. So in the injectable arm, so the long-acting injectable arm and the oral arm, and they found that within a window of 48 and 96 weeks, there were no individuals who experienced virological failure, but then when they looked all the way through to 96 weeks, there were 4 individuals in the long-acting injectable arm and the same number of individuals in the oral arm. And when they looked at emergence of resistance, although these differences were not statistically different, there were 3 individuals who had developed integrase resistance in the injectable arm compared with the oral arm. And similarly, the ATLAS study and the ATLAS 2M study. So the ATLAS study randomized individuals to have injectables monthly versus a common combination of antiretroviral oral medication. And again, for virological failure and virological suppression, the effect didn't cross the non-inferiority arm, showing that the injectables were just as good as the oral medication. And then they took it one step further. They compared having a monthly injectable combination of the same drug versus 2 monthly, so increasing the duration between intramuscular injections, and found that actually, whether you gave it monthly or you gave it 2 monthly, they didn't cross the non-inferiority arm, and one was as good as the other, which is what sort of led to our clinical recommendations now. And patients who are eligible can have bi-monthly injections of combination of cabotegravir and rilpivirine. And certainly there's been a lot of interest even amongst our patient population locally here in Addenbrooke's. So another development that I mentioned earlier was this idea of receiving a pill to prevent acquisition of HIV in uninfected individuals. And there have been 2 large international studies, the IPREX and Partners PrEP, and 1 UK study, which have showed that overwhelmingly there's efficacy of PrEP at preventing HIV infection. And this has become part of the NHS England recommendation as of March 2020. And this is some data that showed the effectiveness of PrEP in an American population. So on the y-axis is the probability of remaining HIV negative. And these are amongst discordant couples, so MSM men and transgender women who have sex with men. Just over 4,000 of them who were diagnosed with an STI were asked about their PrEP use, and then they were then followed forward prospectively. So real world efficacy of PrEP. And they then follow these people up for many months. And they looked at whether they had PrEP or they didn't have PrEP. So the bold line were those who weren't taking PrEP, so the HIV negative partner who wasn't taking PrEP. And in the dashed line is the HIV negative partner who was taking PrEP. And you can see quite a significant difference, the adjusted hazards of 0.16, which works out as the risk of HIV infection being reduced by 84% amongst those who were taking PrEP. And actually, in all 5 PrEP users who became infected, they'd all actually stopped using PrEP and not taking it as prescribed. So that demonstrated that actually from the controlled studies, yes, there was efficacy for PrEP, but actually in real world, that there is also some effectiveness of this approach to reducing HIV transmission. But that all sounds great, but in real world, there are difficulties in getting this into routine practice. A combination of availability, sort of cost in different settings of the world, health insurance, the cost of drugs, etc. But also particularly amongst marginalized populations. So this data considers transgender women who have sex with men. And then they basically looked at these individuals along the continuum or cascade of care, and found that they identified in this study 751 transgender women in 6 cities in the States, and found 100%, found a cohort of these people who were eligible for PrEP. And then they then asked them questions about their awareness, or the bar graph drops down to 84%. So 84% of them are aware about PrEP. You then look at the next sort of potential barrier to them receiving PrEP. So are they health insured, or will their insurance cover PrEP? So that drops down to 74%. And then, they asked them, are you actually using PrEP? That drops down even further to 23%. And then are you, so this is sort of human behavior factor here. Are they adherent to PrEP? That drops down even further. And this is not unusual. You see this across the globe when you examine the cascade of care for HIV at every step of the way. The proportions who are doing these things seem to fall off. So lots of work in trying to identify what the barriers are to keeping 100% of people who are eligible for a treatment adherent to the treatment. And again, this is a similar sort of study looked at, again, thinking about vulnerable populations and sort of intersectionality, men who have sex with men, and transgender women of color. And again, when you screen for eligibility to PrEP, the numbers are such, and then whether they're eligible, whether they're referred to have PrEP, whether they're then linked to care, whether it's prescribed. And at each stage of the continuum of care, you lose people. And I guess what the study also highlighted was that actually, again, thinking about sort of intersectionality and vulnerable populations, that transgender women were particularly at risk of sort of following off this continuum of care, which is concerning, because the estimated these are studies from America, and the estimated prevalence of HIV amongst transgender women is as high as 28%. So having access to what we know is an effective means of preventing HIV infection is key. So U equals U, I've mentioned it already, means undetectable viral load equals untransmissible HIV. So undetectable equals untransmissible, is what we refer to as U equals U. And these came out of studies done here in the UK, which essentially looked at serodiscordant couples where the HIV positive partner was on antiretroviral therapy and was on suppressive antiretroviral therapy, but these couples were already not using barrier contraception, so weren't using condoms and hadn't used condoms for many years. And they looked at just over 900 couples, a third of whom were MSM, and they took detailed, they applied a detailed questionnaire where they inquired about their sexual activity, practices, really detailed, so that they could estimate the risk associated with actual exposure. So from Partners One study, which was the initial 900 couples, a third of whom were MSM, they found that following 58,000 condomless sex acts, there were no events of transmissible of HIV being transmitted. They then continued on this this study and recruited a further cohort of just MSM men, so that the evidence was balanced. So you had the same quality of evidence for heterosexual as well as homosexual sex, and they found that actually even amongst just MSM as well, following 17,000 condomless sex acts of all sorts, that in those who were on antiretroviral therapy and suppressed, so undetectable viral loads, there were no episodes of transmission to their partners. And the upper limit, importantly, the upper limit of the confidence interval of this estimate of 0 was also 0. So we could confidently say that it was impossible to transmit HIV to your HIV negative partner if you're on antiretroviral therapy and you have remained undetectable. So that was good news for the HIV positive population. So I'm going to move on to talk about HIV cure, and you might ask, you know, why pursue a cure agenda? You know, we have effective antiretroviral therapy, we have strategies to prevent transmission, we can keep our patients healthy and allow them sort of live long lives and protect their partners. Why pursue a cure agenda? Well, you know, it still remains to be said that HIV is a stigmatizing condition. The cost of antiretroviral therapy is also an issue. So I think we estimate that it costs about £10,000 a year to treat an HIV positive patient. In various parts of the country, there are issues with access and stockouts and how you store certain preparations properly. There are issues with side effects of some of the medications. And it still requires an individual to remain adherent to their treatment and take a pill daily. And most importantly, when you ask people living with HIV, you know, they're interested in a cure. So I think that's sort of a very good reason to continue to sort of pursue that cure agenda. And you know, a couple of things have happened over the last decade or so to instill excitement and hope in the HIV research community that this is in fact achievable. And on the screen here, I have pictures of 2 individuals and one individual who still, we don't know their identity. And on the left here is the Berlin patient, the so-called Berlin patient, Timothy Ray Brown, who was diagnosed with HIV, but unfortunately also developed acute myeloid leukemia in the mid-20s in 2027. And he needed a bone marrow transplant. And so he was lucky enough to get a matched donor who had this Delta 32 mutation in the CCR5 receptor that I've mentioned earlier. And he had intensive chemotherapy, conditioning and radiotherapy to kill off all his cancerous immune cells. And then this allowed the donor cells to rebuild essentially an entire new immune system for him, which was resistant to HIV by virtue of this deletion in the CCR5 receptor. And he had to stop his antiretroviral therapy because of problems with his treatment, with other problems from the cancer and the treatment. And he had pretty severe graft versus host disease. But despite stopping his antiretroviral therapy, the HIV didn't come back, and he was demonstrated to have a sustained cure. But unfortunately, his cancer, the AML, did come back in 2020, and he passed away at the age of 54. In the middle here is Adam Castillejo, who is also known as the London patient. And he, again, diagnosed with HIV and developed lymphoma, Hodgkin's lymphoma in 2016, and then underwent, again, a bone marrow transplant with this Delta 32 mutated donor. And he had less aggressive pre-transplant conditioning and remained and as a consequence had milder graft versus host disease, but he remained on his antiretrovirals for a little while after treatment, But because there was no evidence of HIV looking in his blood and in his latent cells, basically, the decision was made to stop his antiretroviral therapy, and he's remained HIV-free since then. And then more recently, there's been the New York patient who was presented at CROI earlier in the year. So this is we know she's a middle-aged woman of mixed race origin, and she again had HIV and complicated by acute myeloid leukemia, for which she received a stem cell transplant. Because of her mixed race heritage, there was always going to be difficulty in finding a matched donor, because we know that people of minority ethnic groups aren't very well represented in bone marrow donor registries. And at this point, actually, I will make a plug for the British Bone Marrow Registry, and I would encourage anyone listening to consider donating some of their blood, so to increase the diversity of the pool of bone marrow donors. So she had previously screened umbilical cord blood that had this CCR5 delta 2 mutation, and she's gone on to do well. So so she similarly has remained HIV free. So all of this sort of gives sort of hope and excitement to the community that it is, you know, possible to achieve HIV cure. But we could have discussions about whether this is appropriate for all HIV patients. Certainly, you wouldn't be offering your well patients chemotherapy and radiotherapy and offering to do bone marrow transplants, because obviously they come with risks, but these individuals had complications that required that treatment. So clearly reasonable approaches in their case. And this is just to describe how this works. So this is an HIV particle which attaches to the host cell by the CD4 receptor, and this causes a conformational change such that the virus then attaches to either of co-receptors, CCR5 or CXCR4. The vast majority of HIV are CCR5 using. So as you imagine, if there is a mutation in this receptor, then the virus is unable to gain entry into the host cell. So there's a 32 base pair deletion in the CCR5 genome, which causes a frame shift and renders this unable to make contact with the HIV particle and allow it to infect the host cell. And this is a paper just describing Adam's treatment course, which you can read up in your own time. So published by my PhD supervisors group, Ravi Gupta. And again, this has sort of led to various approaches to achieving HIV cure. So some of the approaches that have been considered or trialed are, for example, the shock and kill, where latently infected cells are reactivated, which then makes them produce more HIV virus, and then targeting that virus with intensive antiretroviral treatment or antibodies or a vaccine. But largely, this is still has been unsuccessful in patients. Another approach is the block and lock or silencing strategies. And rather than sort of trying to wake up these latently infected cells, you sort of drive them into a sort of a deeper latency and prevent transcription of HIV virus. And you keep those cells basically latent forever, such that HIV doesn't come out of those cells. People have tried sort of very early therapy, so treating people as soon as their diagnosis is made or as soon as they get infected, but this hasn't proven to be effective, because when antiretroviral therapy is stopped in these individuals, the HIV viral load rebounds. People have talked about considering genetic editing strategies such as using CRISPR-Cas9, to edit mainly the CCR5 receptor, because obviously it's been demonstrated that this is a sort of a bona fide means of preventing HIV or achieving cure. And finally, what's been talked about more is therapeutic vaccines. So these are vaccines that don't target the virus per se, but target the human or the host immune system. So by either boosting antigen presenting cell action or increasing the cytotoxicity of CD8 T cells, or penetrating into sites where replication is occurring but are not accessible to antiretroviral therapy, such as the brain or other compartments of the body. I'll skip the slide in the interest of time. This basically was just showing the parameters of Adam as he was followed up post-transplant. And I'll just briefly mention the field of HIV vaccines, which unfortunately hasn't been very successful. The one vaccine that stands out was this Alvac vaccine, which is a recombinant canary pox vaccine combined with a GP120 boost, so sort of 2 vaccine prime and boost regimen. And it did show some promise in a study in Thailand, where this is the analysis of the intention to treat analysis, which looked at the probability of HIV infection on the y-axis and years of follow-up on the x-axis, and individuals who received the vaccine. So these are uninfected individuals followed up over time, and those who received the vaccine and those who received the placebo. And it showed a 31% reduction in HIV acquisition in those who received the vaccine, but with a just sort of significant p-value. And there were thoughts as to, well, actually, do we have something here? Could we take this forward? And so this was taken forward in a trial in South Africa, where the vaccine was tweaked to be subtype specific. So the GP120 is the envelope of the HIV virus, and it's highly variable amongst different subtypes. And there's a geographical distribution of the different HIV subtypes. And the feeling was, if we could develop a specific subtype targeting targeted vaccine, that maybe will be able to achieve so efficacy. And so they took this to South Africa. So South Africa has a predominant subtype C HIV virus. And unfortunately, the virus showed, the vaccine showed no difference between those who received the vaccine in blue and placebo in red for women, and for men, those who received the placebo in gray and the vaccine in yellow. And over 24 months of follow-up, there was no reduction in the in prevention of HIV. So that study was stopped by the DSMB in 2020 because the vaccine didn't appear to offer any protection. But there are ongoing studies of various other vaccine combinations. So this one is an adenovirus vectored vaccine with displaying a bigger bit of the virus envelope, so GP140. And another one that's ongoing as well. And we wait to see the outcome of these studies. So I will just finish by just proffering some thoughts on sort of the similarities and differences between the HIV pandemic and the SARS-CoV-2 pandemic, because, you know, in our living history, these are two viruses that have managed to sort of achieve pandemic proportions. And interestingly, there are some similarities between both viruses in that our immune system sees what's on the outside of the HIV virus, so the envelope, and what's on the outside of the coronavirus and SARS-CoV-2 virus, which is the spike. and vaccine strategies generally and therapeutic strategies have generally targeted these things that are sort of immunodominant on the outside of the viruses. We found that these strategies had been unsuccessful in HIV because the HIV envelope is highly variable when you compare, and because this is a retrovirus, RNA virus, which is very error prone. Its replication is very error prone, so you get lots of changes in the viral genome, compared to a SARS-CoV-2, which is thought to be evolving a bit more slowly, but not as slowly as we all initially thought, because obviously we've seen the emergence of various variants with distinct lineages emerging. So a positive thing, I guess, with SARS-CoV-2 is obviously by the nature of the type of virus it is, RNA virus, positive strand RNA virus, it doesn't integrate into the host reservoir, but HIV does that and establishes latency, which adds to the complexity and challenges with eradicating HIV. But looking back at sort of the body of scientific work that has come out of the HIV field and the SARS-CoV-2, I think a distinct impression that I'm stuck with is that in 2 years, the amount of advance that has been made in the SARS-CoV-2 pandemic has been quite something to behold. Lots of scientists have gotten together and leveraged their expertise and have given us vaccines, therapeutic intervention. It has been really has been a triumph of what the scientific community can do if we work together. And I guess I can only hope that that sort of way of working will be harnessed and utilized to basically try and solve the HIV problem. So in summary, I think there have been some real advancements made in the field of HIV treatment over the last 4 decades. We've talked about cure strategies and how the CCR5 co-receptor is now a bona fide target for HIV cure and remission. And I guess I will end with some hope in saying that I do hope that the HIV field can leverage on successes of the SARS-CoV-2 vaccine development and apply some of those lessons learned to the HIV pandemic. And I will stop there and stop sharing my screen and be happy to have a discussion or take some questions or hear some comments. And thanks again for listening.
Thank you very much, Dr. Collier. God, I've just been very informed from your presentation. I've got just 2 questions. A lot of the figures you had was based on the UK research and outcomes here. Do you have figures which relate to work with the vaccine within the African continent, and how has it stabilized, has it decreased? What's the current status of that?
So I think it's fair enough to say that the burden of HIV is in sub-Saharan Africa. So the vast majority of people who are infected live in sub-Saharan Africa. So I've spent some of my working career in South Africa, and so HIV in some of the populations I've worked with is highly prevalent. So you get populations where up to 1 in 3 or 1 in 4 individuals are infected with HIV, which serves 2 purposes. So firstly, it sort of normalizes it in a sense if so many people have it, and it becomes sort of less of a big deal. But also, it has a funny way of making it seem not that important because it's one of many other problems.
Absolutely.
I think certainly I mean, these observations are not unique to sub-Saharan Africa, really. If you go to bits of the United States, the prevalence of HIV in certain communities and marginalized communities is probably, and outcomes are probably as bad as they are in some bits in sub-Saharan Africa. But yes, not many countries have managed to, say, for example, achieve the 1990 targets, and certainly there's a lot of work to be done. If you want the individual breakdown of each nation's achievements in this regard, they're freely available on the UNAIDS website. And I think it's interesting to have a look at, just seeing how you perceive certain countries to be and how well they end up performing. So there's some sub-Saharan African countries that have done well, like Botswana. You might not expect that, but it's just interesting to observe that a lot of this has to do with sort of political will, and what sort of priority they place on having success with the HIV pandemic.
Yeah, thank you very much. I'll certainly be putting myself forward for the bone marrow, so that's something is probably encourage some of my friends and family to do that as part.
No, I think definitely it's definitely something that we need to, I think, plug a bit more amongst communities, ethnic minority communities, to put themselves forward to donate, because already that mutation is rare in the European population. There's only about 1% of people have it, so it is quite hard to find a match. But traditionally, Black and other minority ethnic groups don't put themselves forward for bone marrow donation. So it would be definitely something to.
Yeah, well, I'll certainly be taking that forward. I think it's very important. Yes, thank you. Gosh.
Yeah, it's my pleasure.
Yes, we haven't had any questions put forward, but yes, obviously that will be put out on Facebook, and it was an excellent presentation. Thank you so much.
No worries, and I'm happy to receive emails if people have queries, so that's fine.
Excellent. All right. Well, thank you all for. Is someone got a question? Oh, no. Okay. So thank you so much for your presentation, and have a good day. And thank you all for those who attended. Thanks for attending and being informed, and have a good day. Take care.